Hello, everyone, and welcome back to the Beyond Pain podcast with myself, Joe LaVacca, and Joe Gambino. In today's episode, Joe and I tackle the very sensitive subject of sciatica and low back pain. We do our best to guide you through the history of sciatica and how it made its way through the healthcare system throughout the years. We also talk about assessing and managing the sciatic pain client, both in a virtual and in-person setting, as well as provide advice on when to consider different types of treatments, including surgery, and how to navigate the pain rules when you're dealing with these symptoms. We hope you enjoy this episode and all future episodes of the Beyond Pain podcast. And without further ado, here's today's episode.
Welcome to the Beyond Pain podcast with your hosts, Joe Gambino and Joe LaVacca. Join the two Joes, two physical therapists, as they discuss how to navigate the uncertainties of pain so you can move beyond it and get back to the activities you love most. This podcast is for Joe, and their guests to share their clinical thoughts and ideas based on their collective clinical experiences. Can this information be for you? Maybe, but we cannot know for sure. Therefore, it is always worth talking to your healthcare provider to make the best decisions in your care before you implement anything on this podcast. And please use common sense.
Welcome back to the Beyond Pain podcast. I am one of your hosts, Joe Gambino, and I'm here with the lovely co-host, Joe LaVacca. You can find us on Instagram, as always, at Joe Gambino DPT. That'll be for me, and for Mr. LaVacca or Dr. LaVacca over there, at Strength in Motion _PT. This podcast is also found, it has its own Instagram channel, Beyond Pain Podcast on Instagram, and we also have a channel on the YouTube, Cups of Joe _PT. Not sure why that's the only one that doesn't have the Beyond Pain branding, but because we've relaunched this bad boy since the Cups of Joe 4 episodes that we created back in like 2015. I guess that's the reason there. And then, as always, shoot us a DM. Just DM us the word podcast. We'll be more than happy to just open a conversation with you and talk more. It could be about your pain, it could be not about your pain. We just love to connect. And there's an application form as well in the show notes. So if you ever feel like you need some help with your pain or anything that's going on, feel free to fill that out, and one of the Joes will get back to you. Joe boy, how you doing?
I'm doing well. I got the ladies here this fine weekend. Well, they actually came in last weekend. We had a little family party, get-together celebration. They have since stayed. We went to a Met game last night. That was a lot of fun. We are now going to have a movie day after our growing world-renowned podcast here. We're going to go to lunch and then go see Inside Out 2. Have you seen Inside Out, Joe? I guess you're not into the movie. You have? Okay.
Yes, I have. I'm pretty sure I have.
It was good. It was a solid movie. Yeah. I appreciated the way they talked about emotions and growing personality traits, and then made these things more complex as the girl got older. So now I'm really excited to see what they do with her, I guess, being in her formative teenage years.
Mm-hmm. Well, you're going to find out real soon, Joe.
I know. I'm hoping that this movie will teach me a few things about how to deal with the growing emotions of a 13-year-old and 10-year-old girl. So, fingers crossed on that one, but I'm looking forward to that. And then we got this is technically, we're recording this leading up to Father's Day weekend.
Yes.
You got any plans for Father's Day?
I will be getting an early round of golf in. I got a 7:36 tee time, so I'll wake up a little early, go enjoy some time playing golf, and then whatever Jen has whipped up for us, and just chill and hang out with the family the rest of the day.
Wow. What a man statement. I'm going golfing and then whatever my wife has cooked up for me, that's what we're doing.
Yeah,
Nice. Nice,
we
man.
We go, for Mother's Day and all that stuff. I plan a day, and
That's it.
we
That's
do. I
it.
just want something chill. I just want to spend time with the fam, and if we go to eat or whatever we end up doing, it's gonna be fun.
So it's nice. So you guys surprise each other. Is that what I'm hearing? Like you don't know what's gonna happen.
We
She
usually
doesn't know what's
ask
gonna
if
happen on
there's
Mother's Day.
something you want to do. Like Mother's Day, we went to the beach because that's like Jen's favorite thing in the world. It's about like a 2-hour drive from here.
Very cool.
And then, we were talking, and I was like, oh, well, her birthday is like the weekend after Father's Day. So I was like, all right, what do you want to do? It's actually in midweek. I was like, what do you want to do for your birthday? And she looked at me, she's like, go to the beach. So we're going to go to the beach.
Yeah.
We have off on Wednesday, taking off on Wednesday, Juneteenth, take off.
That's right. That's right. Juneteenth.
Not
that's
work
right.
on her birthday. So we may go and stay the night down like the Wilmington area and just chill. So it'll be fun.
So that's the same day. Jen's birthday and Juneteenth, same day.
She's the day before.
Okay.
She's the 18th.
Got it.
Yes.
I was gonna say, I was like, then you have a reason to take off now. Well, I think it's actually a national holiday. I think even like banks and stuff are closed now too, right? So
yes,
that's great.
Most people,
That's
I don't think everyone gives Juneteenth off. I'm not too sure.
So if they don't, they should.
Exactly. Well, enough about all that fun stuff. Today we are talking about the lower back. We're talking about sciatica and other potential diagnoses, and you put a lot of effort in here with some notes. I'm taking a peek at it now. So why don't I'm going to let you just kick off this conversation. Have some ideas. I kind of like this because I feel like you go out and you get the data and you take a lot of the research and put it in here, and I just come in and the anecdotal.
There we go.
I just like to throw my clinical experience in there as we kind of go along. So I think it's a great tag team here.
We have a 1-2 punch going here, Joe. It's really nice.
Again,
and
right? We got the philosopher and Joe LaVacca there, and then you have me.
Well, you asked me something last week, and this is what's going to tie into, I think, leading into our sciatica pain episode. You asked me last week if I had learned anything and what I had been reading, and I shared some things about the book Super Communicators. And I got to say, I learned a lot of fun facts about sciatica. So I was hoping to start with fun facts, if that's okay with you.
Mm-hmm. That is fantastic. I love that.
All right. Well, first fun fact. It actually comes from the Greek word ischias, and that actually translates to pain around or coming from the hip or thigh. Here's also another fun fact. At the time when people were talking about ischias or sciaticus, and then I think it kind of progressed into sciatica and sciatica, people were way more concerned when the pain just stayed kind of around the hip rather than traveling down to the leg or the foot. And really, because back then, it probably meant a much more serious diagnosis, like you actually had a really true hip pathology, or there's a chance you probably had tuberculosis. So I could see why having some nerve pain down the foot, maybe back in the day, was probably a little bit more comforting than maybe walking around with this idea that you had tuberculosis.
Right.
So a few few more people came on board. I didn't take everybody's name. I wanted to kind of keep it light and just fun. So excuse the fact that I did not put dates or names here. But if you want dates or names, I'm happy to put those in the show notes for everybody. But we're going to break down sciatica into two different parts now: nervous and arthritic. And nervous sciatica was believed to be because of excess cold. So all you needed to do was go apply some heat, go to the spa, put some soothing ointments or balms on it. And then I was realizing, that's a lot of the things people do today for their sciatica.
This is very Eastern medicine, especially, Jen's mom, she's from China. The whole thing about cold is they hate anything cold. You have to do something warm. When Jen was when we had Olivia, she refused to allow Jen to have anything cold. No ice cream, no cold water. Everything had to be hot. Because that's what's going to actually allow her to heal and everything like that. It's interesting.
Yeah, well, I think that's a good point because I didn't think about the wellness side of this too.
Mm-hmm.
I was just more thinking of like the treatments clients come in and tell me they've done. I went to the massage therapist. I got infrared therapy or sauna or like a hot cold whatever. But maybe that's where like the whole idea of like having tea came from when you're feeling blue or feeling down, right? So you
Mm-hmm.
get that warm, I guess, energy. You mix the yin and yang of keeping everything in harmony, I guess. So that's a fun thought. A little progression there from
Mm-hmm.
sciatica.
Yeah.
How about this for other treatments, Joe? Cautery. So we would just take a red hot iron, put it right there on the lateral aspect of your leg and your gastroc. Basically, if you can think of like where your fibular head is or like the lateral side of your shin, just put a little hot iron right there to cauterize that nerve from traveling down
Mm-hmm.
into your foot. We were
So
doing
really,
lots
what
of wild
if
shit to
this
each
if this
other.
was still today, I mean, we would be having the cups of Joe branding and going right into the
That's right.
aspect of the hip to stop sciatica from progressing.
That's right. That's right. Well, maybe right. And I mean, I know now we're about to back for a little bit, but like maybe this is where the ideas of like injections came to be because they probably weren't injecting too much back in
Hmm.
the 1700s, right? It's like, hey, well, we just stick something hot on your skin, and now you just have a new set of problems. I don't think your nervous system will be focusing on your sciatica pain anymore because you've just been significantly mauled. Uh, but
Well, now treat this
um,
burn wound.
Oh my God! Yeah, I know. Geez, then you get probably back then too. Your leg was going to get infected, and then they were just going to amputate it anyway, right? I mean, that's probably the next logical progression.
And
I
then you
didn't
have
think
phantom
deeper than
leg
that.
pain, and now we have a whole new set of issues, right? So that's
Yeah,
funny.
yeah. But I mean, it is interesting. Here's the last fun fact, right? So I'm going to butcher this poor man's name. Dominic Cotugno. I don't know if anybody has the actual pronunciations of names. I butcher names all the time. I'm not good at saying names. Are you good at saying names, Joe? You have a nice name, Joe
Yeah,
Gambino. Like
yeah,
I like
yeah.
saying it.
No,
It's fun. Yeah. So anyway, in 1756, he actually wrote the first book on sciatica, and he actually started shifting perceptions due to some new anatomy and physiology findings that were emerging in the field. And his idea, because he was also the first person to identify cerebral spinal fluid, was actually that there was this excess fluid kind of on the nerve itself. And then his treatments were cupping, blistering, and acupuncture because sciatica for a really long time actually became known as Contubno's disease. So kind of interesting. So again, like all these initial thoughts, oh, it has to be fluid. Oh, it has to just be from cold. I mean, this is 300 years ago, and we're still doing a lot of those things, which I find pretty fascinating.
yeah, and then the Eastern medicine themes are popping up here again: cupping, blistering,
Mm-hmm.
acupuncture. Right? It seems to be they found the tricks first.
Exactly. So I thought, so those are just some fun facts. What do you think about those fun facts? I actually kind of liked a lot of the connections that you were making there, Joe, because I wasn't thinking about the back and forth with today, all that
Guess
stuff. So
I'm
that
I
was
guess
fun.
I'm the philosopher today, Joe.
You are making lots of connections for us here. So I think the other thing that I always like to do when we talk about a specific topic, and I started doing this a lot when I was teaching, is the lack of definitions. And I think this is when we really we kicked off the podcast, right?
Hmm.
Defining pain and sharing definitions. I think I think we asked Tyler, his definition of relationship with pain. I think we asked that at Mike. We'll ask that of future guests as well because I always think it's kind of really interesting to hear that. But do you think the term sciatica is overused, underused, misunderstood? I'd like to get your thoughts on that, and then we'll try to maybe dive into a more appropriate definition together.
Yes, I would probably say overused. And I mean, again, right? I mean, it's probably like, at any time I think anyone has any sort of like radicular pain, doesn't matter where it travels, right? It's automatically sciatica. And trying to think if even I hear that from like other medical professionals too, right? Where like they had come in with a presentation of having some numbness tingling and they said their doctor told them that they had sciatica, right? But then when you look at the presentation, it doesn't match what you would expect from sciatica. So I would definitely say or think that it's definitely overused, but whether or not it's overly important, I think that it is, we should be educating patients on what we think is actually going on, but it's not harmful for them to think it's sciatica versus like if the nerve impingement was somewhere else, unless it's actually going to change significantly the treatment that you would be prescribing, so to speak.
Yeah, I think we'll definitely close on treatment thoughts. But I agree with you. Anybody that has pain into the leg, I think instantly names it sciatica, right? From the best information I can kind of put together, it's probably better to talk about sciatica into more of a broader classification with just like nerve root issues, right? So nerve root issues we can maybe use interchangeably with sciatica, but the real key, and this came through a few different resources, is that your leg pain has to be worse than your back pain and typically extend down to the foot or maybe even toes. So I found that sort of like a nice way to maybe delineate what is a true nerve root issue. Because when, I did some cross-referencing, the other thing about leg pain is that when we stimulate almost any tissue in the back, it can refer pain down to the hip, down to the hamstring, and even just slightly below the knee. So this is where I think maybe, the wording does matter a little bit, just from like maybe a clinical sense, because maybe this is where prognosis comes in, because nerve root issues typically can take, maybe a lot longer than, non-specific back pain to clear up. And we're maybe not using that as a guiding light. Maybe, I start to overreact as a clinician, like, why isn't this getting better? We should probably send you for X, Y, or Z treatment. And maybe certain things happen that don't necessarily need to happen. But I also was thinking about a couple of courses that I think me and you have taken. And one of the ones that first came to mind was FR, or functional range release. And when we were doing spine work, I remember a few of the instructors specifically talking about a posterior longitudinal ligament of the backside of the sacrum and saying, if we can palpate this, this will mimic pain going all the way down the leg. Then I thought how in school or in some other palpation course, we would talk about sciatica. Do you remember sciatica? Did they talk about that? Like where the glute medius or the muscle on the side of your hip can also sort of like refer that sort of like pain down the leg when it's deeply palpated or strummed. So that kind of jived, and I don't think I ever really kind of like, again, like put those things together. So in your sort of opinion, I know you're doing a lot of virtual stuff right now. Are you trying to decipher if it's coming from like a lateral hip, posterior this, and if you do, how are you kind of setting that up in your virtual experience with people with nerve root pain or sciatica?
Yeah, I think, obviously presentation is, one of the clearer signs that I think there's like nerve root irritation would be, how far it travels down. And then I also think about like, from movement perspective, like what is it responding to? I think with what you said as far as nerve root stuff, not responding as well or as quickly as other things becomes a very determining factor for me as far as like, what might be going on. Because if we can do some, because I think that you can have nerve irritation without necessarily having like a nerve root issue, right? Like you can still have some of these like underlying neurological things that happen. So it's how do you start to tease these things out? And then like once you start testing movement and going through movement, and you see what kind of irritates things and what makes things feel better, right? You can start to, okay, well, maybe even if I couldn't fully distinguish between a nerve root issue or just some other neural issues going on, or maybe it is coming from the back, right? But I can start to get an idea like, okay, well, if we do nerve glides, they respond positively. If we move the spine or we load the hip this way, right, there's a positive response. And now I start to just get all this information that's from a movement perspective, right? And I try to treat these movement issues versus saying like, if I really am struggling coming up with like something really does seem like a nerve root issue based on the symptoms, the history. I feel like the history gives me almost everything that I need. And I feel like my testing at that point just becomes like a confirmation of the bias that I get from their story. And if I'm having a hard time, piecing together the pictures or what I would expect from how they're presenting doesn't quite match what they're showing me for movement or not responding the way, then I would just refer out to somebody in person or talk to their doctor or wherever they need to go at that point, right? Because I can't say that I'm going to have the answer to every single problem that somebody comes to me with. But at least I can give them now at that point, right, the education of what's going on, why things are mismatching, think about some other things that they might need to think about, and then let's go see the appropriate person from here to rule out any sort of things that can be potentially, that would really impact conservative care, or, the rehab process, so to speak.
Right. I'm really glad you said that education piece. And I think for me, the education piece is probably the biggest thing that has helped me manage this, even from an assessment and a treatment standpoint, right? So we mentioned that if we're trying to decipher if it's a nerve root issue or sciatica, we said leg pain worse than back pain. So that was really helpful for me at the time, right? Now, and again, like understanding maybe the length of symptoms that happens. The other thing is with your straight leg raise testing, it seems to be, it's not that the limitation of the straight leg raise is a positive finding, it's the actual recreation of the sharp and very localized symptoms that the people are feeling. So I think that's a big thing to understand for everyone is that, hey, my hamstrings are tight and I have a little bit of pain into my hips. It doesn't mean that that's a nerve root issue or a sciatic issue, right? If you have that leg pain and you go to like raise your leg and it sends the same specific signal, that's maybe a little bit more of a sign of maybe something we want to dig deeper into. As always, age is maybe a factor too. It seems that, this is a more middle-aged process, maybe from the age of like 40 to 60, it seems to affect the most people. So I'm always kind of keeping that in mind as well. So if they're really young, is this really truly a nerve root issue? If they're maybe a lot older, is there something else going on? So I always got my antennas going out with like the really young and probably, the really older clients that we see. But then here's I think maybe the biggest one that has kind of, again, helped calm me down as a clinician is this the idea of like radicular pain and actually radiculopathy and how to maybe, like you said, send people out or refer people out. And from my understanding, radicular pain is sort of what we're talking about right now with sciatica or nerve root issues. So it's sharp, it's localized, it fits a pattern, but it's usually a sign of increased nerve activity, right? So the nerve is fine. It's actually a healthy nerve. It's just doing too much and overreacting to mechanical stimulus, right? As opposed to radiculopathy, which is nerve function, and that's typically a loss of maybe nerve health. That's where you're going to see reflex and maybe even sensory loss. So I think when in doubt, for anyone, if you're seeing weakness and if you're doing reflex findings, those are maybe things to highlight a little bit more because you cannot fake a reflex test. And I think that's really important whenever we're dealing with radiculopathy or radicular pain anywhere. It could be in the arms too. If reflexes are diminished, that could maybe be a sign of something a little bit more serious. And that's probably when I would definitely refer out to people or at least get more people on the team that would be able to offer, quick decisions with maybe an injection or, at that point, maybe potentially surgery. But I like what you said before, because I think less than about 2% of these radicular pains really come from like a disc compressing on the nerve that requires surgery, right? So I think that, when we think about how prevalent low back pain is, it affects 90% of the world. And probably dominates a lot of your caseload as it does with mine. But I only have maybe a few people in this year that I encountered who've had a low back surgery at any point in their life, right? So I think that kind of jives a little
I
bit.
think, I was saying initially, right, like herniated discs, we know that there's some research that say that they will resorb, they can heal over time, right? So, is that necessarily something? And I think really when it comes down to surgery, it's really just like how badly does it impact function? Does it improve over time? Can they tolerate? I mean, I've seen people with nerve root issues, right, where it's like a significant impact on their days and they can't do anything without pain. In those cases, right, you're probably going, surgery is something that should be probably highly considered at that point, because if you can't move at all and you can't even do anything to desensitize the symptoms, well, we're going to need something a little bit more to get that process started. So here's things like that. And also one thing I look at, and I think, if you're somebody listening to this that has it, is there normally what I see, if there's like an actual nerve root issue, we would expect that, like, if you did anything, flexing the hip with the straight knee, if you bent forward at your spine with the straighter leg, right? Like all these things, or even just bending forward in general, right? They're going to reproduce all these symptoms. So if there's mismatches in, one of these things kind of reproduces the symptoms a little bit, but another one doesn't, well, then is it, then I start to say, okay, well, maybe it's not really as much of a nerve root issue as it is just some of these positions being more, targeted to some sort of, it's right, it's still probably nerve tissue that's being irritated, but it's not going to be something that's as, as deep as kind of like this really, radiculopathy that's really starting to cause the nerves to have this issue. And I think motor loss is really that big one. Like, we know, right? Those are red flag findings, right? If someone has motor loss, if you're like, all of a sudden something feels significantly weak in a short period of time, a doctor's visit in that case isn't necessary.
Yeah,
So,
especially if that's progressive too, right? Like, again, and if you've had nerve root issues and you still have some weakness that's stable, I think that's different than I think what me and you were talking about. Like progressive motor loss is the thing to sort of really kind of pay attention to for everyone. I know we're throwing out a lot of these words and everything else, but I do want to remind anyone that's suffering from this is that most of the time, this gets better, right? It does have a pretty favorable progression, albeit maybe slower than some of us would like. So a very small number of people, about 15%, seem to fully recover, no issues within about 3 to 4 months. An additional 30% of those people it's going to maybe take a year, but for the most part, most people, about almost 80% of people, are going to gradually see this road get better and better over the course of the first 12 weeks. So the history is favorable. That's going to probably bring me to the point of, well, what can we do? What can our clients do to maybe further their progressions along, ease some suffering? And in terms of treatments, do you have any, like, again, initial go-to treatments? Like, you go through your assessment, right? We're thinking that this is sciatica, a nerve root issue. You're doing some virtual stuff. I know I have probably like a rehearsal list in my head, right, of things I want to take people through, or at least show them initially. Do you have anything like that? And if so, what are your first initial go-tos?
Yeah, I think in cases where if it's like a true nerve root issue, true sciatica, it really depends on how if we do make it to go through an assessment process and all that stuff, it really depends on how they respond. Depends on whether I'm going to keep them on, keep working with them or not, or do I need to refer out. If they respond favorably, usually the first things I really do is do some sort of nerve glide, right? Sciatic nerve glide, start them on their back, start to find easy ways to get that into spine flexion and get the spine moving, and what can they do from even a hip mobility perspective to start to open things up, and what can they even tolerate. So that's I would probably say there, but I would say the first things I'm always going to, just to see how they respond, is doing some sort of gentle nerve gliding, just to see if it starts to either, if it's going all the way down to the foot, does it start to centralize things? Does it actually hit that numbness or whatever sharp pain that they're feeling? Does it start to get up the leg closer to the back? Does it start to bring down symptoms? Does it allow them to move a little bit more freely? And then really, depending on how bad their symptoms are, that's really the first step, by like bringing down pain, calming down the system, so that this way they can actually start to move it, unload it, and do things like that. I'd probably say that's where my starting point is. But that's I think a harder, because it really just depends on where those symptoms go and how bad that person's feeling, to really decide, what those next steps are going to look like.
Yeah, I totally agree. I think sliders and tensioners are probably the number one thing a lot of people go to. Even clients, when they come in with the pain, if they have seen a provider or they haven't, because everyone's so educated now with YouTube and Google and everything else. So like, yeah, a lot of people tell me, yeah, I've done sliders. I've done a lot of the active gliding stuff. And from the things I was reading this week, they do seem to be fairly beneficial, especially when paired with a physical therapist or maybe a movement practitioner that you're doing it with, right? Somebody that's going to coach you through the movement, be there with you, maybe touching you, maybe reassuring you a little bit, right? And then I think maybe even more so was this idea that for people who maybe can't develop or maybe afford the time of an exercise program, multiple manual therapy visits, chiropractic care, physical therapy, you name it. This seems to be a really nice thing that people can do on their own, that's cost effective, that, won't take them really a lot of sessions to really understand. I mean, and whether it's virtual or in person, I've never really had anyone really struggle with the idea or concept of the slider or tensioner. So I think that should definitely probably be in our bag of tricks for clients. Things from there seem to get a little bit more blurry where to go in terms of, do we do stabilization exercises? Should we do functional motor control exercises? Should we just wait and see and just don't do anything? And I think from everything that I was able to gather this week, it's essentially meeting the patient where they at. What can they do? What do they enjoy? What do they tolerate well? And ultimately, what can they be successful with when they leave, right? So I think that when we compare motor control, stabilization, all these different things, it doesn't seem that one is better than the other. So this should give us a lot of options to say, hey, look, we're going to throw some blanks, there's some breath work I do, or this or that. Well, I don't like doing breath work. I don't like doing this. Okay, well, what do you like? Well, I really like aerobic exercise. I really like biking. Okay, great. This is awesome. We can do that too. So that's where I think that shared decision making with clients can really shine here when we're talking about nerve root issues, because it seems that doing anything plus exposure, right, our sliders, tensioners that we just mentioned, versus nothing or potentially like passive care, just with like your spas and your heat ointments and all these different things, is better, is safer, and doesn't show that adverse reactions are a result. And I think one of the things that people always tell me is, hey, well, I don't want to do anything that's going to make this worse, right? I'm sure you've heard that. I'm sure people listening can relate to that. It does not seem in anything I've read that if you do a slider tensioner, if you do some planks, if you do a motor control exercise, if you do some breath work, or if you go on a long bike ride and your sensitivity increases, that does not mean your nerve or condition is getting worse. And I feel like I need to put that on a t-shirt, right? The biggest adverse responses from a lot of these studies was just a little bit of increased sensitivity that lasts about 24 hours. So how do you guide people if they are progressing some sliders or tensioners, they do get some sensitivity? Because I feel like this is where maybe our classic pain rules, are
read
maybe
my mind,
do we
Joe.
Question those a little bit? All right, do we question these a little bit?
Not really
what do you do with that?
I mean, I think exactly. There's a couple of things I want to bring up based on what you said. One of them is right, like you pretty much just said it, right? Like, hey, if something gets sensitive, it doesn't mean things are getting worse, and it usually lasts about 24 hours. Slight pain under a 4 that goes away within 24 to 48 hours seems to be a pretty good sweet spot for people to actually see progress, right? To desensitize the symptoms, right? So you pretty much just said it based on some research and things that you were reading, right? Like again, right, these themes of pain guidelines coming back over and over again, right, to kind of like, it's okay, right? You're probably, especially if you're dealing with something like this, you're going to experience some pain with movement. Well, we have at least an idea of like, okay, well, if it's not lingering around too long and it just comes up a little bit, maybe depending on that level of pain, right? We can make the adjustments, right? Do we need to back off a little bit? Do we need to continue to do it? Just make sure there's rest and recovery in between sessions so that things can come back to baseline. How can we start to explore this without letting things get worse? So I think you kind of hit that, like you already kind of alluded to it. So I don't know if we need to update our pain guidelines necessarily, because it kind of seems we're kind of right in there. And I was actually going to mention this because you even said like it's giving them what they tolerate, and that kind of always brings me back because clients always ask me like, well, what can I do? And I think we've talked about this on previous episodes, right? My answer is yes. You can go try a bike ride. You can go try whatever you want to do, right? And the thing that's going to tell us you can't is what happens afterwards. Is there a lot more pain? Can you not tolerate it? Because what we do know with almost anything from the lower back, more movement tends to be very, very favorable, right? So we can find activities you enjoy. We can get you on more walks if that feels okay. If we can get you to ride a bike and that feels okay. If we can get you to do some, core work or whatever it is, right? And you start to feel better because you did it, then yes, you're going to do more and more of that, right? Because the only things that we want to do in the beginning is whatever we can to start to bring down that pain response. And the last thing I kind of want to you mentioned with the nerve gliders and the tensioners, and you say paired with the PT, it does better. And I think that just from my own experience, I think why that is the case is because people don't realize that it's not a stretch, right? We're trying to like glide this nerve, and you're not supposed to be pushing through symptoms, because we already know, you and I know, right? And other people in this industry know that nerves don't like to be stretched, right? That kind of force that gets applied to it when you really push through and try to stretch nerve tissue can be very, very irritating to it. So when we're doing these nerve gliders, right, you're just kind of like tapping into the symptom and coming off and tap, like, right? We're just trying to free up a little bit more space for that nerve tissue to move. And I think that's where that education comes in, and that's where that coaching comes in. And then once they start to get that, now that they know, oh, well, I'm not supposed to be like getting all this nerve tension and trying to hold the stretch for 30 seconds, right? And really trying to feel that tension. All of a sudden now they become a lot more effective. So that just kind of came into my head where, like, if you're listening to this and you have back pain, you want to go try a nerve tensioner after listening to this, and make sure that you're not pushing through all these symptoms and that like nervy, stretchy tension in the back of the knee and the calf and all that stuff that can irritate those things. Start off easy and see if multiple reps and sets start to free up more space. And if it does, that's a great sign that those things are starting to work. And then when you get up and walk around, okay, hey, my pain was a 4 before, and now it's a 3.5 or a 3 or a 2. Now you know it's really doing something for you, and you should be sprinkling that in more throughout your day over and over again.
Yeah, I think that's such a great point. I've been telling people doing less more consistently is probably going to be a better recipe for most things than trying to go too hard too soon, right? Not that everyone always listens, but it seems that, this idea of just aerobic exercise, keeping that low to moderate seems to be more neuroprotective for nerves. And this is a big thing to really, maybe take away as a closing point for us here, or maybe a last point, is that, nerves more than any other tissues love blood and oxygen. So when you're getting pain and you are moving, maybe we're moving too much, right? And that's causing some sensitization. If you're not moving and you're getting pain, maybe that's a sign that you need more movement, right? So nerves heal, they hurt as they heal, as I usually will tell people. So don't be, too worried about the ups and downs, right? That's going to come with everything. But I think that if we keep that idea of that nerves love blood and oxygen, this is why aerobic work really makes a lot of sense to me clients. So I think that, big picture kind of stuff is what we just really kind of said for the last 40 minutes or so, is we want to mitigate fear. We want to help you prepare, or help clients prepare for the future. right? Make sense of the pain, educate them, right? Especially on that idea of radiculopathy or loss versus gain. And then whatever it is, just keep finding ways to move as you heal. And, I think there's no probably better advice to kind of take away from our conversation than kind of summarizing those points, right?
No, I love that. And I think that's a perfect summary of everything that it kind of came up on this episode. And again, right, it always comes down to what they're feeling, what makes you feel better, what makes you feel worse, and trying to, especially when you're in a lot of pain, right, like double and triple down on the things that make you feel good. And maybe hold, if you have to, right, hold off on those irritating factors for a while. And then as things start to feel better, add in those irritating factors slowly and start to progress. And that's how we start to use movement, right, in this, like, in the injury space, this like low level progressive overload that the tissues can tolerate versus like using your exertion level, which I feel like everyone tends to do. Oh, I'm starting to feel better. This nerve irritation feels like it's getting better. I know I can go out and deadlift 285 pounds. So I'm going to go deadlift 245 as my light entry point back in. And then you have a flare up because those tissues just aren't ready for that. Right. So now you start to take those movements and you're okay, well, let's see, can you tolerate 135 for a couple sets? Oh, great. Tolerated well, let's add 10, 15% more. Tolerated well, let's add a little bit more, right? And now you're letting those tissues start to actually get the benefit of movement, and you're not exceeding what that threshold is. And as long as there's no pain, you just add a little bit more. And once you start to feel symptoms, well, now we can use those pain guidelines we talked about to start to make decisions. Should we push more? Should we back off? Do we need to rest? And things like that. So I think it's very well said there, Joy Boy.
All right. So stay sliding, stay moving.
That's the new tagline for the podcast. Love it. Well, Joe, as always, love you, listeners.
Love you.
We love you as well. And if you've made it this far on the podcast, extra love for you as well.